I will just
Ladies and gentlemen, we are about to begin shortly. Please be seated and ensure your mobile phones are switched into silent mode. For attendance, kindly scan the QR code displayed on the screen. QR code is also available on both sides of auditorium hall. Assalamualaikum warahmatullahi wabarakatuh. A very good morning to our honorable guests, Dr. Gregory Norbaya Binti Muhammad Ismail, Hospital Deputy Director 1, Head of Department, Specialists, Medical Officers, Nurses, and the rest of respected executive staff. Thank you all for joining our today's CMP session. I am Dr. Nurul Anfal from Wound Care Unit, will be your MC today. Without further ado, I would like to invite Dr. Hafizah Matsaki to present today's CMP with the topic Nasoalveolar molding. Majorly, please welcome.
Assalamualaikum and a very good morning to everybody. Today I'm going to present on, I'm going to share my experience on Nasoalveolar molding. Hello? Hello? Can you hear me? Boleh dengar ke? Boleh? Right, okay. Tapi slide saya tak bergerak sebenarnya. So, I'm so sorry for the technical issue. We tried to resolve this morning, but I think because of, we changed 2 laptops before we changed this laptop. So I think I might need some help from IT because it is not moving at the moment. So, fortunately for those who are in this hall, I'm going to ask you the first question. The gift is the biggest gift I've ever given in any of my lecture. So if you can answer, just raise your hand and just go to the mic, right? Okay, thank you. So this my list of contents. I'll talk about introduction on NAM, the objective of NAM, proposed benefits of NAM, roles, our roles in class management, class cases in which have reside, the conclusion, and last but not least is the references. So the first quiz for those who are in this hall. I think those who are online, I cannot see you, so I want those who are in this hall to tell me who know what is the full name of my department. Just go to the mic. We prepared a gift already. Not dental team. Anyone? No answer? Oh my God. Siapa nak tidur boleh tidur, tak ada masalah. I always say that. You can't sleep. Jangan gerakkan kawan yang tengah tidur. Right, so my first quiz. Who know what is the full name of my department? Tak ada? Wah, okay. Anyone can answer? Yes, can. Hadiah dia besar. Yang first ni hadiah dia besar. So I prepared especially for those who know my department.
Department Jabatan Bedah Mulut.
Salah. Okay, this is the first answer. We always heard from, we get from referral. JBM PITS, is it? No? Who else? The biggest gift I've ever give. Anyway, yeah. So, anyone else? Nobody? No? Okay, the second one will be dental only. No? A big no. Because actually we are being gazetted into 2 departments in dentistry. We have 4 specialties. We have 2 departments and 2 units under OMFS. So I'm not under OMFS, but here in HRPZ, we are known as 1 department. So dental, usually you send to me with dental, right, to dental. Dental PITS, almost there. This is my department. Jabatan Pergigian Pediatric was gazetted in 2012 over Malaysia, or we call it as Pediatric Dental Department. Please, if you want to refer the patient to me, refer to the right department, all right? Because we might confuse a bit. Mine, I'm saying the patient less than 16 years old and OMFS or adult JBM. JBM ni adalah Jabatan Bedah Mulut sebenarnya. So dia sama dengan oral maxillofacial surgery. Okay, or oral surgery. Mine was pediatric dental department, right? Or pediatric dental clinic. So introduction. A growing number of newborns with lip alveolar and palate cleft are receiving therapy using nasoalveolar molding. More than 300 publications on various facets of NAM therapy have been published since 1993. The first one was published in 1993. In the early research of cleft palates, authors aim to accomplish 2 goals. The first one is premaxillary retraction, and the second one is on alveolar segment alignment before lip closure or chilorhinoplasty. Nevertheless, the introduction of NAM during preoperative phase was the first to attempt to rectify nasomaxillary abnormalities, which link to these 2 deformity, unilateral cleft lip and palate and bilateral cleft lip and palate. So what is pre-surgical nasoalveolar molding that I'm going to talk today? It is actually first described by Grayson et al. In 1993 as a technique to correct the alveolus, lip and nose in infants born with cleft lip and palate. So this technique incorporated the nasal stem to the intraoral plate, enabling nasal and alveolar molding simultaneously. And this appliance usually we do for a patient shortly after birth, approximately 7 days. And the nasal stent, based on Grayson technique, they introduce the stent added to the alveolar plate if the cleft is less than 0.5 mm, right? So what is the objective? The objective of PNAM, or pre-surgical nasoalveolar molding, is to restore the normal anatomical relationship of the cleft skeletal, cartilaginous, and soft tissue elements. This one is to facilitate the primary chilorhinoplasty. So what is the duration? Usually in PNAM, in a patient with PNAM, our aim is to put the patient on the therapy for 3 to 4 months until the alveolar cleft is less than 3 mm. And the nostril rim of the affected site has been repositioned. When the patient completes the NAM therapy, the primary chilorhinoplasty is performed. So the technique will, in our clinic, we use a combination of Grayson technique, or I modify a bit Grayson technique and adding some technique from suggested by Figura, which is mostly used. These two techniques has been introduced in 1993. There are many techniques where they put the modifications, so they put their name on it. So they are actually known for their own technique. They are actually adopted the technique from Grayson, right? So the Grayson technique, the original Grayson technique, they take the impression using heavy body impression material. In our clinic, we use silicone putty as soon as afterwards as possible. The impression is taken in supine position. In our clinic, we put the patient in supine position on the table, and in Grayson technique, they put the patient in inverted position on the parent's lap. A cast or model of the alveolar anatomy is made using plaster material. In our clinic, we combine the green stone and the white stone to make the model. The model was made, the initial model was made by the green stone, which is more harder than the white stone. And this white stone was used as to block the undercast so that we can produce not so accurate. I mean, not going into the undercut using the acrylic material. So the molding plate is fabricated on the dental stone model using a clear acrylic with nasal stand. And later, sometimes in Grayson technique, they put the nasal stand and but later, after they get the approximation of cleft area about 0.5 mm. But in my case, sometimes I prefer to put it earlier to get the normal anatomical structure of the nasal bone. So parents are instructed to keep the plate in full time and to take it out for cleaning as needed at least once a day. Initially, it may take longer to feed the child because the child is not comfortable. When you introduce the plate, it is foreign body to them. So if you started to feed the child before we introduce the plate and put the round tube some more, actually patient become lazy to start swallowing. So what happened is that we have to start over. We need some time. I need to refer to speech therapists to teach the patient on how to start swallowing, right? Even in a baby. So initially, it may take longer to feed the infant with the plate in place, but the child quickly adjusted. And most of my patients reported that their child only can drink milk from bottle, by using plate. Cannot drink without it anymore, right? The appliance is secured extraorally to the cheek using retention arm. Okay, as you can see. The retention arm is this one, right? Okay, so the retention arm placed on the anterior flange of the plate and stabilized with surgical tapes. In my clinic, we use styrstrip, 6 mm x 100 mm after placement of lid strapping. The tape and elastics are changed at least once a day. In this paper suggested that appointment should be given every 2 weeks in Grayson technique, but in my patient, we usually give appointment within 1 to 2 weeks to modify the molding plate and the nasal stand with bulb to guide the alveolar cleft segment into the desired position. Parents are instructed to place tapes to approximate the cleft segment. So we started the NAM by putting the lid strapping first before we put the plate. So the plate will be inserted and then we try to reposition the cleft more approximated, okay, into more approximated shape so that it's actually trying to mold actually the bone and the tissue. At the base, actually this tape placed at the base of the nose or nasolabial angle and not low on the lip near the vermilion border. It should be placed to non-cleft side first. So usually we put it on the non-cleft side first and pull it to the cleft side so that we actually mold everything together, right? So this is what I mentioned about nasal stand. Okay, this one usually in Grayson technique they put it later, but in figura technique they put it immediately when they issue the plate. So this one in my clinic they are using acrylic at the bulb to make it as a bulb in the nasal cavity. But in my case, I actually cover it with silicone putty as well to actually reduce the irritation to the tissue. Okay, this is how the patient look like after we put the NAM. So you can see here, I think the picture, can you see the picture clearly? I think online they can't see it clearly. So this one is the plate inside. Okay, it is like a denture. We put it in and then we put the retention arm. The retention arm is for us to put the elastic with the stylus strip to hold the plate in place. And then this is the nasal stand will go and actually it will the function is to mold the nasal cavity, the bone as well. Yeah. Right. So this is a case post placement of the plate of the NAM. So as you can see. Okay, this baby can feed very well after we put the plate in. So actually, in some patients, we advise the mother to try on breastfeeding if they can. But if they can't, we ask them to either use a spoon. We teach them on how to use a spoon, or they can use a shrink type needle, the shrink type tape. Sometimes in certain center, or if you ask a patient to register to clap-arm, they will give the NUK tape. Okay, to the patient. So actually suggested in certain center, they suggested the NUK tip because the point that the opening is pointed upward. Actually, it is used for patient with colic. Okay, it is anti-colic tip. But in my case, or in class patient, we give the NUK tip to and we modify. We rotate the opening. We put it directly on the tongue so that it won't go into the palate because when the milk goes to the palate, and patient, you don't remove all the milk that retain in the mouth at the palate area, it might go to the lungs after when we put the patient into that position, right? Same to this patient, the mother will learn on how to feed the child. Okay, this patient is on the patient is bilateral clavate and palate patient on NAM. And then as you can see on this patient, we don't put the nasal stand earlier. We put it a bit later because the nose is not so big, so it is quite difficult for us to put the bulb in. Okay, and then this is the last case, the last patient I'll show you today, where we ask the mother to feed the baby using shrink tape, right? Okay. Okay, so what is the proposed benefit of NAM? The first one, it reduces the extent of the main nasal surgery by correction of the nasal cartilage deformity, colimolar length deficiency, and alveolar malposition prior to the primary chilorhinoplasty. Elongation of the columella in patients with bilateral cleft, and overall reduction in the financial and psychological burden of the patient and caregiver. So what is our roles in this cleft management? So actually, we are not a surgeon. My role is to assist infant feeding as early as possible to achieve a weight of 10 pounds within time frame of 4.5 kilo within 3 months, right? So at this moment, actually we achieved 3 months, 10 pounds in 3 months old child, right? So to motivate infant's mother to breastfeed or feed with breast milk to the child, it actually reduces stress, improve milk production for 2 years, and it is following the WHO recommendation for breastfeeding, and it is actually immune booster prior to surgery, and to help the plastic or OMFS team for continuous care of cleft infant to teenagers. So we are helping them with the kilorhinoplasty, paratoplasty, and alveolar bone grafting. So as you can see, I'm referring to this book on breastfeeding only. It is a very thick book on breastfeeding, so you can go and read in this book. And it mentioned that breastfeeding actually help to reduce the mother's stress, boost the immune system and all that, okay? And they mentioned that when patients start to feed directly from breast, it increases the production, right? So just following that. And weight gain, actually, this is our guidelines on monitoring the patients post-NAM. So we look at the weight gain guidelines for infant and children. Okay, this is my references. Usually we use it as 20 grams per day in children less than 3 months. Okay, so we are also following this one to give the consultation, feeding consultation to patient. I think we all following the same. And then this is from this book, the Tarascon Pediatric Inpatient Management. Right, and then as a conclusion, normal weight gain for infants is 20 grams per day with consideration of 10% weight loss within less than 1 month due to expel of meconium and the start of breastfeeding and movement. So what about our cleft cases referred to as pediatric dental clinic, right? Remember pediatric dental clinic, right? So we started receiving referrals since more than 10 years already. So I think a long time ago. So since after COVID in 2022, the case reduced to 22. And during this time, we started to do NAM for our patient after our course in September 2022. And then we started to receive more reference from multiple teams. Right, so in 2023, we received about 31 patients, 18 out of 31 patients receiving NAM during this time. And this year alone, until July 2024, we received about 28 patients. I hope we receive more. We get more referral from other departments, yeah, especially pediatric and plastic team. Right, so type of cleft cases referred to our team, more than 60% referred due to cleft lip and palate, be it unilateral or bilateral. And then type of management, mostly we do conservative. In certain patients, sometimes we do feeding plate and lip strapping only in patients with cleft lip and alveolus. And for cleft lip and palate, most of the patients underwent PNAM, right? So, I just want to share my experiences in dealing with patients with cleft using PNAM. So this is my first patient, right? First in September 2022, when I received the course, right? When we see the patient presented with right unilateral cleft lip and palate. This is the gap, right? You can see the gap is quite big as you initially. What we did was we placed the PNAM, right? We take impression, chest side, and then we place the PNAM. But this time, I'm following Grayson technique, so we don't put the nasal stand yet. So after, during third visit post NAM, we do correction to the retention arm, right? And then after that, at the age of 3 months, during this time, I think plastic started to do the surgery after that. So at 3 months old, when patient is on PNAM, we put the nasal stand and bulb. As you can see, can you see the bulb? Here is the bulb, and this one is the nasal stand, right? So this patient actually can fit very well after that. This patient still on follow-up under us. The mother was very happy to have a treatment done here, so she wants to continue the treatment here. And this is the patient post-surgery. As you can see, the nasal contour is quite a very good nasal contour as compared to without PNAM, I suppose, yeah. Right, so 3 days post kilorhinoplasty under plastic team. This case was done at the plastic team, right? So what we want to achieve as nearly normal as the normal the level of the nose, right? This one actually is a surgeon hand. So we depends on them. We are assisting them to make the result, the outcome of the surgery better, right? Okay, this is a patient after 4 month post-kilorhinoplasty at 7-month-old waiting for palpoplasty. As you can see, the nose, right? The nose level is I'm quite happy with this result, right? Actually, the nose is quite critical because we cannot repair the nose once patient went for first kilorhinoplasty. And kiloplasty can be done before school age, but rhinoplasty cannot be done during school age. So we need to wait a little bit more. So I think, yeah, this patient after that, and the parents live in Penang, stay in Penang, but the follow-up still with us every 6 months. Yeah. So as you can see, the patient is very happy. I think at the lip you can see some kind of some kind of adalah sikit here and there, but I think they can have revised surgery later. So the second case on right unilateral clavicle and this one alveolar, sorry. So you can see, as you can see here, there is some kind of overlap of the bone, and then the space is quite big, the gap is big. What we did for this patient is we put PNAM with Nasoalveolar and bulb. This one I'm following modification of Grayson and Figura, right? And then for this patient, as you can see, the nose, the contour of the nose higher a bit as compared to the first initial visit, which flattened, totally flattened, right? Okay, as you can see here, as shown here, as you can see, the gap become closer, right? So here after surgery, as you can see, the nose, beautiful, right? Like a normal patient. Okay, this is what we need. Okay, bilateral clavicle and palate for this patient is a 2 days old baby boy, right? Referred to me with bilateral clavicle and palate. This one they referred to me because of difficult feeding and patient is on RALSIO. So, fortunately for this patient, the RALSIO is not long. So there is no rotation of the premaxilla area. So I'm able to put the PNAM with the strapping. This is a combination of strapping and PNAM. So as you can see, we don't put, this one also I'm following Grayson technique. So we don't put the nasal stand and bulb yet at this point. So after that, we put the nasal stand and bulb, right? And you can see that the nose is a bit higher as compared to before, flattened, totally flattened. Now, as you can see, the gap become closer, approximated prior to surgery. 1 week prior to surgery, it's easier for the surgeon to operate on it. Yeah? Right. So this is after surgery, day 1 and day 3 post-kilorhinoplasty. As you can see, the nose looks good, and the lip also looks really good. So this one, patient at 7-month-old, right? You can see the lines, all the lines that we want is there. Okay, the lines are there. And then, as you can see here, this patient after, I think this one is after 6 months of review, 6 months of the previous review. So you can see that, you can see all the lines, right? The nose contour looks good. So I'm happy with this result. And the last one is the most challenging case ever, because this one is a big 1 month old baby girl referred to me at 1 month old. Patient has a bilateral diagnosed with bilateral clavicle and palate with rotated premaxillary area. Why rotated? Because of the RALSIO, prolonged RALSIO, due to patient admitted because of pneumonia. So this mother is from Tanah Merah. So they referred the patient to me to derotate the premaxillary area. This one is the initial presentation of this patient. So you can see that it is rotated to the right. It's quite difficult for us to start with the surgery. I'll show you later how the surgery without PNAM actually causing a lot of aesthetic problems. So for this, you can see, no, because of RALSIO, I removed RALSIO during the first visit to my clinic. And then we constructed the PNAM, the plate first, okay? Actually, the PNAM, but with no retention, the nasal stand and the bulb. Okay, as you can see here, still rotated. But after this, I modified the strapping. I combined the strapping technique to strapping to reposition the anterior segment, and we put the PNAM after that just to approximate the tissue. Okay, all right. In this patient, you can see that it moved a bit to the center, right? A bit to the center. So I think I'm quite happy with the result after we modify the strapping technique as well as we put the PNAM. Okay, in this patient, we put later the nasal stand and bulb. Right, as you can see, the nasal stand is looking like it totally blocked the nose, right? But patient can breathe because they have a lot of holes in it. Yeah, the palate holes, the nose, a slight opening on the nose. Patient happy, tak ada masalah. Kita yang nampak macam tertekan kan, macam stress kan, looking at this. So, yeah, this patient, I'm so happy. Before the surgery, we can see that the premaxillary area has been rotated to this center. Okay, you can see the comparison. This one is initial look, right? You can see that it is rotated to the right side. And then after that, after some time, after we combine the technique, it is moved to the center, and now it is at the center. It assists the surgeon, right? Looking at the first, I'm sure the aesthetic-wise will be compromised. So this is the patient 1 week post-kilo rhinoplasty. I'm quite happy because when patient came to me, I can see the wound is like a trauma wound, not like a cleft patient, right? So you can see the lip contour, the lines, all the lines were there. Okay, happy with the result. The nose mother was very happy. The most important part is the parents, right? So this is after 3 months. You can see the healing process was very good. Okay, all the lines present. And then it's a study model. If you can appreciate, I highlighted the yellow as the center, the bone that we want to move it to the center. So this one, you can see the gap. Here, the left and the right side gap. Okay, more of the left side, right? This one is the left, this one is the right. Okay, sorry, sebab gambar ni dia terbalik. So imagine dia terbalik, right? So now it become more approximated, which I'm happy, right? So this patient after 5 months, and I wanna share with you the comparison when we put only feeding plate. Previously, when I started my service as a specialist into 2019, we do only feeding plates because I've been taught doing the feeding plate in patient by Datuk Kalai during that time. So feeding plate, we tried on our patient. Yes, we can achieve body weight of 10 pounds within 3 months. However, the surgical side is not as aesthetic as one. You can see the projection, the protrusion of the premaxillary area. It is so difficult for the surgeon to work on it. So my role is to assist the surgeon. Okay, as you can see here as well, this one, no, rotated. I don't try to derotate. If I derotate, I think the result might be better for this patient. So we hope that we can receive more referral if you put RASQ. So please refer to us for us to monitor the patient's premaxillary area, especially in bilateral clavicula and palate. Right, for this patient as well, if we try to reduce the premaxillary area a bit, I think the surgeon will work really fantastic. Yeah. So for this patient, actually this patient also on feeding plate, and you can see, no, not all NAM will work on all patients, right? But in some patient, it might help with the nasal with the nose. Yeah, you can see the level of the nose is quite aesthetic as compared to in a patient with cleft without treatment, initial treatment. Yeah? So comparison pre and post NAM. So you can see in this case, you can see the nose contour, the nasal contour. Okay, it's a bit. I think this patient also have a bone deformity as well, the deficient bone at that area. So NAM, without NAM, it actually causes more worse to the patient, right? So in this case, you can see protrusion of maxilla, right? Aesthetic-wise, it's compromised a bit, but the surgery went very well. You can see the lines. The surgeon has tried their best to put the lines all together. But I think if we help the surgeon, we might get a better result for patient. Yeah. So issue with cleft patient on feeding plate only. Yeah. Improve feeding. However, it will not contribute to surgical management. No reduction of cleft area. Hence, it will not be helpful prior to kilorhinoplasty. Need accurate reach. So impression should be accurate to get the reach and sulcus with some undercuts to create suction during appliance insertion, right? So the challenges during initial therapy, less experienced operator, me lah, especially kan, kita kurang experience. insufficient financial support, because to start with, something you have to start with your own money. Yeah. And then as inexperienced technical staff, which I need to, until now, we need to still guide them. The mechanics of the NAM still from me, but they are helping me with the construction of the appliance. So as for conclusion, NAM therapies become a more frequent part of the CLAF treatment regime. A better course of treatment will be determined by case selection and compliance, particularly during kilorhinoplasty. So I'm going to show you some video. This one was made in 2020, 2022, 2021, okay, finished by 2023. So hope you enjoy. Can you hear the sound? Saya rasa itu saja setakat ini saya punya presentation. So no one is a hero in club multidisciplinary team. The real hero is our patient and their parents in this club battle. Club is a real teamwork. So these are my references. With that, thank you. Saya diarahkan untuk bertanya soalan. Tapi hadis-hadis saya sediakan. So untuk soalan pertama, apakah role kami sebenarnya? Siapa ingat? Dapat satu pun cukup dah. Saya bagi hadiah yang first tadi. Ada siapa nak jawab? Okay, alright, thank you.
Assalamualaikum.
Salam.
Menggunakan pembedahan,
Okay.
juga menggunakan video information.
Okay, alright. Sebabkan doktor ke? Puan Fazila. Okay, so disebabkan Puan menjawab dengan betul, tepat, so saya bagi hadiah paling besar ni. Soalan tak ada orang jawab kan? So, boleh? Terima kasih. Soalan kedua, apakah kedua soalan. Ada soalan tak sebelum tu? So, saya ada soalan banyak tadi, tapi saya lupa dah lepas saya dah bagi susu ni. Berapa reference yang awak nampak tadi dekat depan? Berapa reference yang saya letak? Siapa ingat? 4? Siapa jawab? Alah, tak boleh orang yang sama. Ada tak orang nak tolong jawab? Angkat ambil hadiah je. Okey, silakan. Silakan. Dengan bangga sebut nama, departmen mana?
Sister Haniza dari Department Medical Daycare.
Okey. Okey, terima kasih. Boleh? Right. Berapa kes yang saya share tadi? Kes, real case. Ada 6 hadiah tau. Yang ni hadiah yang saya bawa lah. Berapa kes? Salah. Salah. Siapa jawab 4 tu nak bangun jawab ke dekat mic? Sila. Ambil hadiah je. Kita claim hadiah je hari ni. Bagi nama dengan jabatan mana?
Assalamualaikum, saya Mahasiswa daripada
Okey, so jawapannya? Okey, terima kasih. Berapakah kes saya pada tahun ini? Sampai remember? Who remember? Yes, bangun cepat bangun. Ke mic please. Saya dengar yang belakang dah. Saya ganti jawab yang lain. Okey, berapa tadi? Okey, sila. Okey. Ya, terima kasih. Alright, ada lagi tak hadiah dia? Ada lagi kan? Lagi? Ada soalan tak sebelum ni? So saya rasa itu saja. Ada soalan boleh tanya Terima kasih.
For the very good and informative presentation. We now welcome any questions or opinions from the audience. If there's no more question, I would like to invite the Secretary Nasoalveolar to deliver the certificate of appreciation to our respected presenters. Please welcome. Thank you, Dr. Putri Nurbayu. With that, we have come to the end of today's CME session. The upcoming CME will be presented by Volker Unit with the topic of wound assessment and photography. Thank you, everyone. Assalamualaikum.